You normally have a really nice backdrop. Have you changed that? Have you?
No, I built these cupboards, so
Oh.
took a lot of time and effort. So I want to show them off. So
Well done.
blood, sweat, and tears went into those cupboards. Right then, good evening, everyone. So welcome to tonight's webinar. So we're back with another ScotLens lecture, all about living in a myopic world. So we've got Scott Brown from ScotLens, who's an optometrist, orthokeratologist, and specialty contact lens fitter, and founder and owner of ScotLens company. So Scott's pretty well known as a myopia and a myopia management expert in the industry. So he's going to talk you through the lecture today. At the end of the lecture, we're going to have a bit of a Q&A session. So if you do have any questions that pop up into your head throughout the webinar or at the end, just pop them in the chat function, and then we'll answer them all at the end. We've also got Pauline Bradford from ScotLens as well. So she might be able to pick up a few of the questions too as we're going through, but we'll do our best to get all the questions answered today. So without further ado, I'll hand you over to Scott. Over to you, Scott.
Great, thank you, and thanks for the introduction. You've kind of stolen my thunder from my first slide, which is, just to introduce myself. So Scott Brown, I've been an optometrist in independent practice for 20 years. The practice that I went into, we got referred NHS irregular corneal stuff, and we also did ortho K. So it's been a kind of a key part of my career for the last 20 years. I now do, I'm a clinical director at ScotLens and do professional services along with Pauline, answering all your inquiries and queries that you might have about fitting. My interest in myopia is really just a hobby, and I'm lucky enough that I get to go to conferences, I hear keynote speakers, and I'm always trying to apply the stuff that I learn into practice. So that's really what I hope the talk today gives you some ability for. Before I get on to talking about myopia, I want to talk a little bit, kind of a little bit of commercial stuff about ScotLens. So ScotLens is, there's no equality in life. You know, if we look at optometrists, we all sit the same exam, and then we all have different levels of abilities and expertise afterwards. So ScotLens, it's the same in the contact lens world. ScotLens genuinely produces some of the best quality GP lenses that exist. And that's really come from, I'm a bit of a nugget and a bit of a kind of obsessive about stuff. So it's kind of come about from me being in practice and wanting to fit my patients with the best lenses and having effectively a lab of a disposable from the point of view of the equipment that we staff it with. And GP lenses are certainly not stagnant. This is, you see the engravings, markings in there. So we've just put in a new engraver for our nocturnal ortho K lens and other lenses, but starting with that one. From the point of view, they're probably the first lab to put this laser in. So it's a lower powered laser. Usually the lasers that are used in the industry are CO2, which are a little bit overkill. So we're now engraving the lenses. Now that's nothing fancy, we've engraved the lenses before. The engravings are going to go on the back surface. That's a little bit interesting because, of course, on a ortho K lens, the back surface doesn't touch the cornea because there's the minus lens tier, the sort of tier lens minus shape. So it doesn't touch the cornea. And of course, if it's on the back surface, it's not touching the lid. So it's the perfect place to put it onto it. You can see the markings so that we'll have the lenses marked with the serial number of them. But so ScotLens is kind of at the forefront of GP manufacture. We got our certification for being carbon neutral last year, partly because our manufacturer is really clean and really efficient. That made it a lot easier. I'm an ex-scuba diver. I couldn't call myself a surfer. I do aspire at surfing, but I wouldn't call myself a surfer. But we obviously manufacture a product that's made in plastic. So kind of my understanding for the sea, so we donate a pound for every nocturnal lens fit that we do to Surfers Against Sewage. This was the last donation that we gave them for £1,000. So would you consider becoming an orthokeratologist? So the way I see it, well, hopefully after tonight's talk, you might be a little bit more inclined if you're not an orthokeratologist. So I go to my dentist. My dentist then might need to refer me on to a specialist who would be the orthodontist, and that orthodontist fits me with technically an orthodontics, something, but we don't call them that, we call them braces. So I kind of see it the same. So we've got optometrists, they would refer on to an orthokeratologist and then they fit the patient with night lenses. Now I like the term night lenses because it's easier for patients to understand what things are and to communicate. Rather than ortho K or nocturnal, I purposely don't use my own brand nocturnal with patients, I just tell them these are your night lenses. I find it much, much better for communication. Now, why has my screen stopped moving? Oh no. Where's my slides gone? There we go. So in Edinburgh, if you looked up opticians, you would find there's about 80 opticians. So one of the advantages, of course, in being an orthokeratologist, well, nightlenses.com lists all the orthokeratologists in the UK. So there's fewer orthokeratologists. So if somebody's looking up night lenses, then they're going to get funneled in a direction. So there's only about 16 or 17 practices in Edinburgh. So from a commercial perspective, it's quite a good thing to do to have this specialist thing. Our nocturnal lens has been out for 22 years now, so quite a long time. And ortho K lenses and night lenses in general, they have to be fitted much more accurately than standard GPs. We have this micron accurate fitting where you just send us the topography, or you send us Ks and Rx and topography metrics. We then send you a lens. And we manufacture with this free-form technology. It's a manufacturing process called lathe to eye. That means that every lens is guaranteed. And that's kind of I personally would guarantee that. So we make every single lens to an accuracy of 0.02 millimeters, which is twice the ISO standard. And effectively, our manufacturing process means that we check every surface. So we're checking not only every lens 5 times in manufacture, it means we're checking our manufacturing process about 400 times a day. So every lens is just made perfectly. From you guys, if you're fitting, you get 2 free exchanges with a new fit guarantee, full credit. So there's no risk for you for lens cost for having a go at fitting your nocturnal ortho K patients. And we do the payment plan either 6 or 12 monthly. I prefer 12 monthly in my patients. And if you're on a payment plan, you get a free replacement pair within the cycle that you're on. And there's no contract. You can stop anytime. Just return the lenses. Now, this is the term, I think so, the crypto guys say it's a bull market just now, I think. Is it bull market where the market's gone up? So this is where we're at with our nocturnal sales. So effectively, growth since 2020 has been really good. If you're a practice, you should be on this because it's a really good way of getting new patients and new patients that are super interested. And how successful is it? Well, it's super easy. Basically, you send us a map, we'll send you a lens. And that lens has, if we look at fairly big numbers, so this is the figures just from last year, 92% are successful fits. So that's over a couple of thousand fits, 165 practices. Now, 67 practices had 100% success. Now, that could be, of course, they might only fit 2 or 5 patients over the course of the year. So that doesn't mean much. But if we look at some bigger numbers, we've got some practices, our top practices in 23-24. Now, this is patients. So one practice fitted 39 patients with 100% success. Another practice, 68 patients with 99% success. And another practice, 68 with 97. So they were the kind of top performers. We've also got practices that are lower performance, one doing 60 with a 77% chance, one doing 48 patients with a 71. So why do we get this variation? Well, it's kind of the same as with multifocal contact lens fits. You see variation between practices. A lot of it is down to do with the communication of the practice. It's also to do with patient selection. So I'm quite conservative when I fit. I can't be bothered fitting the weird and the wonderful and the high prescriptions because I kind of know that there's going to be I'm going to have to work harder at maintaining them, probably not get an optimum visual outcome. So I would fit fewer patients but have a higher success rate. Somebody might fit more and be more speculative and fit more. And if we look at this case, so this is one of the kind of real extreme ends, so very high myopia. This patient was happy to wear top-up glasses afterwards, but the optom wanted to go for a full correction. So we went for the full correction of lens. And you can see, amazingly, this patient came down to nearly plano. So this is a unicorn or the hen's tooth, because of course you could probably fit 30 patients at that prescription, and this would be the only one that would be successful. But this just shows you some practices will be more speculative and will just say, well, okay, I know that I'm still going to have a 70% chance. I'll end up with more patients. More patients means more patients on my database, which is good. Right, let's get on to the topic. So living in a myopic world. We certainly are. And this paper that came out on my birthday last year kind of summed it up really well. And this was quite an important piece that basically where Michael Lipson has summarized what was going on with myopia and effectively looking at all of the organizations around the world where we saw this shift. The philosophy had changed, that we are no longer just regarding myopia as refractive error, and it's now treatment of myopia and myopia progression as a disease. And that term kind of disease can make communicating myopia a bit harder. And if we look at the American Academy of Ophthalmology, they define myopia as a significant prevalent disease in children with increasing rates of progression. So this can make us a little bit uncomfortable, and it can be difficult to communicate with. It's also difficult because when we're dealing with myopia with children, of course, the consequence of that myopia is not going to cause them issues with their eyes until they're much, much older. So there's maybe a 40-year delay. And of course, there's another factor, which is we might have done an eye test, and then we've only got 4 minutes at the end where we have to kind of broach the subject and try and communicate quite a lot. And that was one of the things that we did at the Eye Care Conference in Glasgow. So Eye Care Conference in Glasgow, really worthwhile going to. January in Glasgow is, it's not kind of the most pleasant place to be in the world. And probably, to be fair, actually January anywhere in Britain is not that great, but it's not Eye Care in Faro or somewhere. But Eye Care Glasgow, but a great conference, and thoroughly recommend you go and vote. We ran some peer review sessions. And one of the statements, I'm not going to take credit for it, but the statement on this slide came out of the peer review session. So we said, look, you've got this 4 minutes. How do you guys communicate, or how are you going to communicate myopia? And this was one of the statements that I think sums it up really well. I'm not going to read it out. You can see it, or you can see it on the slide afterwards. But it's quite concise. So today we've found that you have this short sight, which is actually myopia, which is a disease, can cause problems when you're older. And then the statement that the group came up with was a bit like using sunscreen, preventing skin problems when you're older. So, of course, that's skin cancer, but we're quite happy that we just know, right, we just slap sunscreen on our kids, it's going to stop them getting problems when they're older. So likening it to something that's very familiar, which is good. And then what we can do is offer you this wires out. So I thought that was a really good statement that came out from the conference. And the other thing that came out from the discussion groups was, well, what are the advantages and disadvantages of myopia being classed as a disease? And the only downside was really this communication issue that we've got, because, of course, diseases are, well, you might have gout. Now, if you have gout, nobody has any sympathy for you. They just think you've eaten too much pate or drunk too much port. Whereas you could have the Black Death that's associated with dirty rats, a horrible disease, and all that. So disease has this negative connotations, and that was really the limiting factor. But the advantages that the groups raised was, well, it helps kind of reinforce the importance of it. It can provide motivation. But then most importantly, we are at a position just now where myopia management is quite kind of elusive and quite expensive. So if we get more funding, more research, it's going to lead to more products, and that's going to bring the cost down for folk, which are the main advantages. So I feel that myopia being recognized as a disease is a really positive thing for the industry, and we need to just kind of embrace that and move forward. Also positive for the industry is what's going to happen with myopes. Now, of course, not positive for the individuals, but positive for the industry. Because over the next 25 years, we're going to see effectively 15 million new myopes emerge that we're going to have to manage. So again, that bull market that I showed you, the kind of graph going up for ortho K, well, that's kind of going to happen with optometry. So we're in a fairly secure place that we know we can invest in this in the future going forward. And we should invest in it academically and in businesses. So this is a resource on a website that I find really useful in that 4-minute chat when we say, well, here's some information for you. So this is myopiachat.org. I wrote the text for this. Every statement that's in this is referenced, and on the website, the references are all there. So you can send the patients a link to this as a digital asset or as a PDF. You can download it from the website, and it covers effectively what we need to tell patients about myopia, and it explains it in really simple terms, hopefully patient-focused communication. So over the talk, I hope that you either get a refresh of information that you already know, or hopefully you might learn something that enables you to step up your myopia management over the course of the talk. So let's talk about emmetropes and emmetropia. So I did remember, but I kind of never linked the two, that children start hypermetropic, and then they gradually become emmetropic. And that process, of course, they should stabilize the process of emmetropization, and we can look for this at two age groups. We can look for plus 0.75 at age 6, we can look for plus 0.25 at age 10, would be the normal amount of hypermetropia that children should have. And that, of course, then should stabilize. And if we're in a natural environment, our eyes and our genes in our eyes, and there's 160 identified genes, means that we effectively become emmetropic if we're in this natural environment. So hunter-gatherers, we still see no myopia. In certain groups of populations where they're outdoors a lot, we see lower myopia. But myopia is linked to some genetic conditions. And there's about some rare conditions that cause about 10% of myopia. So 10% come from those conditions on the left. And then we've got kind of the normal vanilla myopes, I term them, where we see this myopic onset. And of course, we do see variation between different ethnic groups, whether you've got parental myopia, a little bit more difference between males, slightly more than females. And also we're starting to understand now about maybe single gene traits that might mean that certain individuals accelerate or respond to different treatments. But the elephant in the room is kind of that if 10% is caused by these genetic factors, then 90% is caused by the environment that we are living in just now, which is something that we can change. Now, we don't really understand the mechanisms. I'm going to do a probably horrible injustice to oversimplifying it here, but if we have this outdoor environment with bright light, different full spectrums, low contrast, high spatial frequency, that environment goes into the eye, stimulates dopamine. The dopamine then attaches to the dopamine D1, D2 receptors. That seems to be the key component in the stabilization of the emmetropia. If that happens, you also get a difference between the release of dopamine during the day and melatonin at night. And that, of course, teenagers, which are renowned for not sleeping very well, that circadian rhythm can be beneficial. And vitamin D is not linked to myopia, but we do see lower levels of vitamin D in myopes, which suggests that they tend to spend less time out of doors. So the outdoor environment is really beneficial. Now, of course, I have kids. I want my kids to go to school. I want them to be smart. I want them to get good jobs, all the rest of it. This graph shows the prevalence of myopia on the left-hand side with the amount of years that the kids spend in school. So you can see right up to grade 12. Now, this is from a Chinese cohort, so you can see that the percentage of myopia is really, really high, over 75% by the time the kids finish school. But what's interesting about this, if this was just age dependent, the graph would be smooth, but it's not. What we see is we see this step change. So you can see in the graph that I've highlighted, we've got kids that are born 1 month apart, but one went to school a year earlier than the younger group, and that step change is the impact of that 1 year's education on myopia. So there's about a correlation between education and myopia, about a quarter of a doctor per year is what education causes from a myopic perspective. So can we prevent this? Well, we might be able to prevent the genes going and manipulate the genes, but there's 160 of them, so it's really, really complicated. We can probably change the classroom environment. This is a glass classroom that's been employed in China to try and let more daylight in, or this classroom is a more recent picture that I came across, which is where they're using to try to reduce the contrast in the room. Now, there's a little bit to unpick in this classroom because it's a Chinese classroom, Chinese flag on the wall. Now, learning environment. So we've got eyesight versus a learning environment. It struck me a little bit odd. So the environment looks fantastic. It looks really great to be in. But there's about 50 kids, I think 48 kids in this room, which in my kids' classroom, that's going to turn into bedlam pretty quick. Not a great learning environment. And the other thing that I thought was a bit odd is this is a Chinese cohort. They probably should have about 50% of myopia. And there's one dude wearing glasses. So the rest, obviously the classroom environment is working really well, or they all wear either night lenses or contact lenses, one of the two. So interesting one. Anyway. Let's move on to myopia. So if that's emmetropia, so what is myopia? So myopia is classified by this refractive error, and it does vary, but if we go with, you have to have more than minus half a diopter. And that's when myopia is being defined as started. And when we look at the eye, myopia is not caused by the cornea. In fact, one of the most important lessons that I want you to take away tonight is the cornea stabilizes at about 3 years of age, and it never changes after that. So your cornea is the same when you're 3, 13, 33, probably 63, 93. The cornea is it's the most powerful lens in the visual system. And of course, if that lens, the most powerful lens, was to change routinely as time went on, the whole eye is going to have to catch up with that. So it doesn't make sense that the cornea changes. It changes when we have a condition like keratoconus, and of course that causes massive disruption to the small changes in curvature cause massive disruption to the prescription. So the cornea is stable, and that's actually something that we should be measuring to screen for keratoconus. I'll maybe put up a link, or we'll send you a link afterwards to some talks and stuff that I've got. So it's not the cornea that causes myopia. There might be a 6 diopter difference between flat Ks and steep Ks, but once you get to 3, your cornea is stable. It's also not caused by the lens. The lens thins, loses a bit of power, but it becomes stable at myopia. Now, the exception to that is of course, adulthood myopia, where we see that shift quite often around the onset of presbyopia, and the myopia can quite often jump up. So that is then lenticular. But the myopia that we're talking about, and with these young vanilla myopes, it's not the lens that's causing it. It is the axial length, and that's why we're hearing so much just now about axial length. So the axial length changes with time. This is also why in emmetropes, the hyperopia reduces, because the axial length grows that little bit, so they become less hyperopic, and they then stabilize and be emmetropic. So it's normal for an emmetropic patient to have axial length growth over their adolescence. So that brings us on to a slightly frustrating term, which is pre-myopia. Now, pre-myopia, so let's look at this graph. I love this graph. This is from the Don Muti study. It's really important because if you look at where, now they defined in the study that you had to have myopia of more than 0.75. At more than 0.75, the group of patients, you can see they classed that as year 0 on the graph along the bottom. And you can see clearly we've got the emmetropes, nice flat line along the top with the myopes coming down. But what we can see from the graph is that they're not actually becoming myopic at year 0. The myopia is starting 4, if not 5 years before the patient gets the blurred vision and the symptoms of myopia. So this pre-myopia, it's not really the term, because if we're thinking about myopia as being the disease, effectively, the disease of myopia is starting like 4 years before, but it's termed pre-myopia. And this phase is super important and will become more and more important with us managing myopes as time goes by. Now, it's really important because the graph on the left is the graph showing you the refractive change. The graph on the right is from the same study, but this is showing us the rate of change of when the myopia kicks in. And you can see that the rate of change is at its fastest before the actual refractive prescription kicks in. So you're getting this acceleration. So if we can do something in this period of time, in this pre-myopic period of time, we can really slow down the impact of myopia. So this period of time for the 4 years before is going to become critical. Now, how critical? Well, this is quite significant. So for every year that we can prevent the onset of myopia, you'll see that there's a ratio, which is that we'll end up with 0.75 diopters less myopia. So for 1 year delay, we get 0.75. Now, if we take that 0.75 and put that into context, so if we look at the Cooper Vision study, so the Cooper Vision study for 6 years of wear of a myopia control device, on average, they got about half a millimeter, which is about 1.3 diopters of difference of prevention. So 1 year of prevention is going to give us more than half of that of 6 years afterwards. So that's how significant this early treatment of myopia could be. So what can we do for the pre-treatment? Well, the good thing, as I've kind of alluded to already with the early slides, is outdoor time is what we should be advising. And this should be something that optometry and the college and all of the optometry bodies are all over, in conjunction with the heart, cardiac and obesity and diabetes and all the rest of the medical professions. Because outdoor time, of course, is going to be so critical in improving all of these conditions, but particularly with pre-myopia. At this point, we also might want to introduce atropine or light therapies. Now, I haven't seen a lot of evidence around light therapies, and there seems to be a little bit conflicting evidence over safety. But if you look at what's going on in the Far East, it's certainly being used a lot more over there, and it tends to then get established to a certain degree, or get refined and then gets established in some form. And atropine is the other interesting one. So at the moment, we don't have access to atropine. It's not on our list and it's not commercially available. Now, atropine is interesting because the optical corrections that I'm going to talk about in a second all work by an optical principle. Atropine works by a different mechanism. So it's working by receptors inside the eye. So there's two different mechanisms of action there. Now, there was an NIH study that came out saying that 0.01% was effectively ineffective. They couldn't establish the effectiveness of it. There is other studies that show it's effective, but part of the problem with atropine is we've not had a pharmaceutical grade option for patients. So all of the atropine that's been used in the studies has been compounded, so it's been made up for that study. That introduces quite a lot of variability and can affect, of course, if you've got variability going into a clinical study, it's going to affect the outcome of the clinical study probably much more. But what we're about to see is two concentrations, 0.01 and 0.03, from a company, Sidnexis, who are just getting pending their FDA approval for pharmaceutical grade atropine. So that means that there will then be availability to buy it, and then also means that we'll get much better information, because that's going to go into clinical studies, and then the outcome will be much, much clearer, and we'll understand, by having these two concentrations, we'll understand if the concentrations make a difference and when we should be prescribing them. So atropine is certainly something that is going to be coming over the next wee while. And this was just a recent study, quite interesting. I think this is the Essilor Stellus lens, prescribing that in this pre-myopic phase, and they did show that it had some benefit on axial length group. But of course, this brings in challenges, because if we're doing anything in this pre-myopic stage, there's some challenges come with that. So we need to have, effectively, we have to have children coming into the practice before they get the blurry vision that quite often motivates them to come in, which means that we really need to have some kind of national screening program or awareness that all kids should be just getting their eyes tested. The other thing is, in the UK, we're probably going to have in the young group about 40% of myopia, which means that we're going to have 60% of patients that will be getting screened unnecessarily, which is quite inefficient. So that may want to get refined. If you've got parental myopia or slightly higher risk factors, you could cut that down or try and cut that down. The other difficulty is, how do we identify these patients that are earlier than the year 0 point? So it needs to be done very accurately. That either has to be with axial length or it has to be with cycloplegic autofraction. So axial length would be my preference for that, because bringing every child in to give a cyclo to is not going to improve our perception in children's eyes from the point of view of, I'll have to go to the optician and get these stingy drops for kind of no point, because kids are going to not have any appreciation that they need to be seen because they're seeing fine. And that also is compliance. If we have this no prescription, are folk going to be compliant, which is an issue. So moving on from this phase of pre-myopia onto where we have refractive myopia. So patients notice blur, they then come in, and I'm sure you've seen these slides before. So this is the standard single vision image shell. We push the image shell onto the fovea to bring that into focus, and it gives us this peripheral hyperopic defocus with a single vision lens. Lets you see in the distance, but it does this to the periphery. And this is quite a bold statement from Dr. Michaud, who's I think Waterloo University, a leading researcher. So providing single vision glasses to a kid that is evolving myopia nowadays must be considered malpractice. Now, quite a bold statement, but I think it shows where the industry and where the academic industry particularly is expecting us to go, which is where you get a kid with myopia, they just should be getting myopia control optics and myopia management. So an indication of where we're going to go. So what we do is we have these devices where we have this peripheral myopic defocused dose, and that brings in this image shell, and that slows down that axial length growth. So we've got specs with myopia control, we've got day lenses with myopia control, and then we've got ortho K. They all have this peripheral myopic defocus, and this is what changes the axial length. So I'm an orthokeratologist. I offer these three options. I kind of find not offering ortho K to patients would be like not offering varifocals to a presbyope. You would say, oh well, I can give you two separate pairs, I can give you bifocals. And people that prefer, the varifocals, well, yeah, they take a bit more expertise to fit, they cost more equipment, that's kind of how significant it is, because patients love ortho K. It's the most preferred mode of optical correction. So what do? Well, we fit a gas permeable contact lens, fits the eye, but it has this minus shaped tear layer. And that minus shaped tear layer then creates a treatment zone. So this is all an orthokeratologist does, which is create treatment zones on the cornea. The treatment zone is the key bit. So this patient, you can see the top left image was their baseline cornea. The bottom left is their review. We then have this subtractive map that shows us the power change, the treatment zone that we've created on the cornea. And this patient sees 6/6 and they have plano residual refraction. So this is what an orthokeratologist does. The cornea responds by this tiny little cellular change. So we get only the epithelial cells change, where we get thinning in the middle, thickening in the mid-periphery. And that, of course, creates a minus-shaped epithelial surface, which gives us the refractive correction. And if we zoom right in, it really is a tiny change. So if the epithelial cells are 50 microns thick, they might go down to 40 in the middle, they might go up to 70 in the mid-periphery. And of course, this is tiny change. We can't see this with a slit lamp, which is why we use the topographer in order to do that. So here's the slide I showed you earlier on. Now, just using the treatment zone, it's kind of the same as using the specs. So if we saw a myope that came in and they were wearing a -2 pair of specs, but they've got blurry distance vision, and we give them an extra diopter, and we give them -3 in their specs, and then that brings them down to 6/5 acuity, we know that their prescription has gone from -2 to -3, so there's an increase in the prescription. And that would be the same during orthokeratology. So we had a patient that came in with a -2 and they had blur, and their treatment zone was -2, and they had one diopter blur. We know that we're going to have to provide them with a treatment zone of -3 to correct for that. So effectively, the topography in the treatment zone gives us the equivalent value to specs or the power that we're fitting with soft contact vision. And this is how we measure it. So this is a patient over quite a number of years, over 10 years. So you see they started off at age 11 with a -2.3, right through to when they were 22 years of age. Bottom right-hand corner, the prescription was -2.4. So again, this works because the cornea doesn't change. The lens hasn't changed, so therefore the power of the treatment zone for this patient has never changed over the period of time. And that's what we would expect. Apart from this one. So patient came in for this exam. Now, of course, patients are always told that the reminder text that goes out, wear your lenses the night before. Patient came in, 13-year-old boy. How are you getting on? Yeah, great. Oh, loving the lenses. Yeah, good. Okay. What can you see up there? It's a bit blurry. Okay. I ended up putting a -0.75 in to get him seeing 6/6 at the distance. I'm thinking, oh dear, has the prescription, has his myopia increased 0.75 in the last year? Put him on the topographer. Topographer shows me this. I'm like, So last year you were getting a 2.35 diopter power change, and this year you're only getting -1.82. So did you definitely wear your lenses last night? He kind of shyly looks over at his mum going, no, I forgot. I didn't wear them last night. So there we go. So the topography shows, effectively confirms that if the patient's being compliant with the treatment. So that's how we use it. An orthokeratologist uses topography. And this one we can see slightly different. So this patient went in -8, already -2.4 doctors. Both parents were high myopes, over kind of -10s. But this patient now, age 20, they have their refractions are -4.03. So they have had progression, but they've only really gone from a 250 to a 4, whereas the parents are super delighted because they're up at -10. So that's how we use the treatment zone. Now that's looking at the treatment zone in the middle on the visual axis, but the other information we've got is what's going on with the peripheral power. And this is this myopic dose, so the myopic defocus dose that I was showing you earlier on. So I always considered this really like a bifocal or a varifocal contact lens, where you've got a distance center, multifocal, and that was an ad. So that would be an ad of a 3.4 doctors. And that helped me with, thinking about that, helped me with managing patients. So I know now that the typical kind of value of this ad that you're getting is usually about the same as the treatment that you're trying to correct. So if you've got a -6, you're probably going to get about a 6 doctor ad. So that helps me manage the patient's expectations. So patients coming in, they're a -5. Okay, so I'm going to fit you with a distance center cornea that's got a +5 ad on it. So that's probably going to cause a bit of glare compared to the -2. So that was how I thought about it, and it was really valuable for communication. And what we've got is this, effectively, that's where the -3.4 doctors is giving you this myopic defocus dose. So not an ad, a MD. But, and yet there's a higher example, so we've got -6, -6.5, and we've got, there you go, 6.5 doctors off the ad. So this patient would be expected to have poorer quality vision because they've got the much higher ad getting caught with the pupil. But what we're actually inducing is more aberrations by doing this. It's not really an ad. And this was kind of highlighted, particularly when the specs came onto the market with these little lenslets, because of course these lenslets aren't focusing tiny little images that our retina can see and can recognize. What they're doing is they're inducing different types of aberrations. So it's the aberrations that cause the eye to respond. Now, if you're a bit of a nugget like me, so you're a topographer, with the Medment, you can actually pull off the individual higher order aberrations and look at them depending on what you've got. I wouldn't really encourage you to do that, but you can if you want to. But you'll probably remember the kind of the table of higher order aberrations that we got. And we're really concentrating in research just now on the 3 in the middle. If you imagine where the 8 ball would go on the, if I got a mouse, I might have a laser. No, I haven't got a mouse. Where the 8 ball would go, the 3 around there are the spherical aberration and the comas. And they seem to be the ones that are easiest for us to track to measure the difference that we get. So we've got the corneal changes, the treatment zone properties that we get with orthokeratology. We've got the kind of the same bifocal, effectively distance center dual focus lenses that we've got with myopia control soft lenses. And we've now got these aberrations being induced with the spec lenses. And when we look at the research studies, they tend to kind of say, well, yeah, let's say 50 or 60%. And that's a 2-year study, which pretty much has quite a lot of caveats. So it'll be a small patient group, be certain prescriptions that are allowed to enter the patients. It's a very controlled environment and doesn't necessarily relate to the patients that we're going to see in practice. But what it does show is that they're all kind of similarly equally effective in the 2-year study. And then we've got information beyond that. So how do these aberrations then affect axial length? Well, if you look at axial length, this is why it's so significant. So we've got an emmetropic eye on the left, and we've got a myopic eye on the right. And you can see and you can imagine on the eye on the right all of the structures and how they've been stretched in order to get that axial length, which is why myopic eyes suffer the pathologies that they do. And this might be a fascinating fact, but this was a kind of point of view of interest that I had, which is that, and no giggling, so the choroid, which I didn't learn much about at university, but the choroid is an erectile tissue. So when the choroid is stimulated, it increases or decreases in its blood flow and is classed as an erectile tissue. So what's happening is we apply an optical device with these spherical aberrations, and this can have effectively an immediate effect on the choroid. So the axial length, and they measure off axis to measure the choroid and to track the changes. So within minutes, you put the optical device on with the myopia control optics. Within minutes, what happens is the choroid starts to become erect, pushing the retina forward, reducing the axial length effectively. But what then happens is you've got increased blood flow in the choroid, and that's now going through and bolstering the sclera. So this is the underlying mechanism for why these optics end up reducing and stabilizing the axial length. So super interesting. And amazingly interesting that the choroid can thin if you give it the wrong aberrations, which is what we see with the single vision optics. It can thicken, and it thickens for a period of about 4 to 5 months. So it lasts for that initial period. So we get a little bit of a change in axial length from this, but actually it's more peripheral. And what the next kind of investigations will be, and it might be that they come into practice, is we might actually have devices like OCT that looks a bit deeper into rather than just looking at the retina, it might look into the choroid, and we might actually be able to measure choroidal change to know how individuals are responding to the treatments straight away effectively. So when do we measure axial length? Well, so we've got an immediate response to axial length that's small with the choroidal response, but we also get seasonal variation with axial length. So you can see here the graph shows that we've got periods of summer, winter, summer, winter, summer, winter. And you can see that in the summer, the line graph is flatter. And then come winter, there's an increase. And this is fairly well established that in winter, you get more progression of axial length. So of course, if you're measuring axial length, you want to kind of measure at the same point every year, the same time of year every year, so that you're getting a corresponding graph to overlay. And you can see there's an error there of around about 0.03 millimeters, which is not massively significant. So best practice for measuring, particularly with ortho K, there's 3 factors that we want to get. So you should measure ideally at baseline. You should then measure at your review. Now that review is going to take place probably between 2 and maybe 4 weeks. At that appointment, we're going to see a little bit of a change with the corneal epithelium, which is where axial length starts to get measured from. So we've got a little bit of a change possibly with corneal epithelium. We're going to have this little choroidal response, and then over the year we want to ideally measure at the same time every year. So measure at baseline, measure at review, and then the same month of the year. And that same month can be quite useful from the point of view of, in a myopia management plan, the regimentation of it almost emphasizes how serious the myopia is, rather than just patients. Of course, they tend to come in, you send the reminder, they come in a little bit later. So appointments can creep into different points all through the year. But is it really that significant? Well, the difference that we get between the variations between summer and winter and the change that we're going to get from a seasonal change or from the initial change epithelial, they're really, really small. So effectively, that's the best practice, but it doesn't really matter. Just do it routinely, but probably compare annual figures rather than 6 monthly, because there's going to be less variation between the two of them. Now, which optical correction is the best? So we've got specs, we've got myopia control day lenses, and we've got ortho K. And again, roughly they all have the same. If you look at the 2-year studies, they're roughly all equal. So let's look at a really good study, and I like this study because this is for a control study with an ortho K group. So each individual one of these dots is a patient. And what we can see is the dots that are paler grey are the control group, and the dots that are dark are the ortho K group. And you can see that the black dots are more concentrated towards the bottom of the graph. And that's the control, that's the reduction in the myopia that they've had. And when we look at the group, we see that 90% of the patients fall into that group where they got a benefit. 20% of patients have effectively stabilized completely. But there is this 10% group of patients that effectively haven't measured as being any better than they would have been if they were just in the control group. So 10% effectively don't respond. And this is also the same information that we see from the MySight study. So again, 23% of patients effectively stabilize completely with less than 0.25 change, and this is over the period. We've got 90% of patients getting a benefit and 10% that would be classed as no responders. I'm always interested by these two down at the bottom, especially the one right at the very bottom. So they had a 0.6 millimeter reduction in axial length over the course of the study. So we need to find out that person's genes, because they effectively could at that point effectively become hyperopic within the context of the study if they started out as a low myop. But so we see from an optical perspective, we know that ortho K, myopia control day lenses, and myopia control specs are all working roughly in the same principle and this aberrations. So we see the same with the two groups. I haven't seen the same kind of data from the Hoya study or the Essilor study, but presumably it's going to be mapped out in roughly the same way. And that's really reassuring for us in practice, because it means that we know that we're going to put our patients into one of these myopia control devices and they stand a 90% chance of getting a benefit. So on the Brian Holden graph, you can see that you can plug in the demographics for your patient and then you'll get the graph. What it means is that 90% of patients are going to fall into that triangle above where they get less correction. Now, as an orthokeratologist, I love this quote from Mark Bullimore. So this is Mark Bullimore, who's one of the top researchers and kind of educators on myopia. He was asked at a Cooper Vision conference, which is the most effective ortho K or multifocal contact lenses. And so if we're talking about the current dual focus lens that is MySight, ortho K wins it by a nose. So we have two super effective methods for myopia control. And again, we're seeing similar spec results for smaller in a smaller study or an individual device study. So I don't care from a patient perspective which one of these options I'm going to give. So the question there about Mark Bullimore, which is the most effective, Mark was very careful with his language, so he's probably picked up on the effective, but he would also be the first to say it's not necessarily the best for your patient. So if you've got a patient and they do not want to poke their finger in their eye, they're phobic about it, or they have terrible hygiene, then yes, you're going to say, well, you want the myopia control specs. If they're happy to poke their finger in their eye and wear contact lenses, then they've then got the option. So I'm not fussed which one of these options that they go for. What I want is the patient to choose the one that they're going to have the best compliance with. And if you're an orthokeratologist, you'll probably be aware that we're starting to now further refine the orthokeratology process to try and boost the myopia control. And we're doing that by fitting smaller optic diameters. So with the nocturnal, you can order the myopia control plus, and you can specify the standard optic as a 650, but you can also specify that as a 6 or a 550 or a 5 mil optic. To try and what we're doing with that is compress these aberrations, that treatment zone, make the treatment zone smaller and compress it into the pupil more. I'm not entirely convinced by the evidence around this so far, because it's all fairly small studies. And this is one of the studies where it shows a 6 mil optic group versus a 5 mil optic group. And you can see that there is a difference between the two graphs. But the difference is all in the first 6 months, which strikes me as slightly odd. And I would quite like to see a study where they start them off in one lens design and then they move to another and see if there's a shift, because it just doesn't strike me. So I'm not entirely convinced by the evidence around this, and that effectively influences a little bit on how I prescribe these the different designs. Because I also remember establishing the design and getting success. And one of the things that we get asked for all the time by orthokeratologists is, can you make the optic zone bigger? And of course, what we see from this is if we make the optic zone bigger or smaller away from the zone in the middle, you can see that the acuity drops off significantly with these patients. So effectively, the designs were set up to optimize the visual outcome for patients. If we deviate away from that, there's a chance that we're going to, well, about 30% of patients, their vision is going to significantly drop off. And if you've got a young child who's getting used to lenses, also making their vision blurry is just a complication that I think they could do without. So what I tend to do is not start with a smaller optic. I would start with a standard optic, and if they get perfect vision, great result, I then might consider reducing the optic to boost the aberrations in their treatment zone, and that can be done under exchange at a second lens time. So that's optic size. We also have treatment zone decentration. Now, if the treatment zone of forms off the visual axis, again, that throws up more aberrations, and that's more beneficial. This is something that we don't really control so much with ortho-K, because you'll see that the alignment zone of a night lens aligns with the peripheral cornea curves. So if we look at this cornea, the alignment is going to be in this zone, and you can see that that is not lined up in the visual axis. We'd expect that's the middle of the circle, so we'd expect the treatment zone to form off-center, and that is exactly what it does. So effectively, we can't necessarily influence this with lens design. That's not a bad lens fit, it's a perfect lens fit. It was the cornea that dictated that the treatment zone was going to be there. And this is a question that I get asked quite a lot. Do I need to axial length before I can start doing myopia management? I would absolutely categorically say no, you do not. And I'll explain to you why. So we've got this pre-myopic stage. And if we think about that, we only have one option. We haven't got atropine or any other options. We have one option to recommend patients, which is that patients get time out of doors. And that could be universally applied by optometry. So we've got time out of doors. So it doesn't matter at this point whether we measure myopia or not. We want all of our kids to get as much time out of doors as they can be, regardless of what their axial length is, what their refractive state is, everything. So we don't need to measure axial length at that stage. We then move into where there's refraction, and if we put folk into the myopia control optics, then we know that we're going to have an outcome which is going to be beneficial to 90%. So again, measuring axial length in this phase isn't going to affect the treatment. We would move patients from one treatment onto another if their compliance was better, or if they wanted, we're going to have better compliance, or they wanted a different option, but the outcome is always going to be the same. So you can be reassured that if you don't have axial length measurement, you can still provide patients with the same outcome that effectively everyone has the option for. Now, what about the 10%? Well, even if somebody's in that 10% and you measure their axial length and they are not responding, at an individual level, you still don't know that they're not getting any benefit. So the axial length measurement would maybe give you some reassurance to say, well, we could stop. But effectively, I've yet to see a patient that hasn't had a clinically visible amount of reduction in the myopia progression once they've gone into one of these devices. So I think that 10% is pretty rare. So do you need it to start? No, you don't. Get started. Should you plan to get it? Yes, I think so. Let's plan to get it, because we are going to see atropine come available. And with any combined therapy, then we want to be able to differentiate. We need to be able to measure the benefits versus the downsides. So you can see, if we took a look at this example, we start atropine nice and early because we've measured the change super early. Patient goes on to atropine, they get some reduction in the myopia, so the graph starts to level out. They then go into an optical correction. Later on, you can see the graph further leveling out again. So if they didn't get any leveling out for the myopia control optics, you might then be able to say, well, you can actually just get a single vision option. And this, of course, is why night lenses is so good, because effectively you get myopia control with ortho-K whether you want it or not. There is no single vision alternative to night lenses, so there is no cost difference. So effectively, if the patient went on to night lenses as this optical correction and they didn't get any benefit, that's fine. They're choosing the night lenses for the lifestyle benefits that goes with it. But this is where axial length is really useful in practice right now, which is actually not the kids, it's the adults. So it's these young myopes that develop myopia as children that we have missed. And this is where axial length, I think, can be more beneficial. Now, again, if you don't have axial length, there is quite a good correlation between axial length and refraction. So if we've got patients over a -6, the graph on the right, you can see the risk factor for sight loss goes up with the orange line. It's more accurate with 26 millimeters, which is one of the measurements for axial length. But there is still quite a good correlation. So again, if you don't have axial length, we still want to be on the patients that are -6, we still want to be providing them with better or more thorough care. But with axial length, we can identify and provide reassurance to the patients that are in group quadrant 3, because they are the high myopes, but actually they have quite a short axial length. So we can reassure them and say, oh, well, this is great. And we can also kind of be more diligent over what we do with the myopes that are in quadrant 4, because they are fairly low myopes, but they have longer eyes. They're more at risk of issues. So axial length gives us this accuracy, which we can then take to other instrumentation that we've got. So of course, the risks with myopia are cataracts, glaucoma, myopic macular degeneration, and retinal detachment. So we've got instrumentation and practice to help us monitor that. So these patients, the myopia management plan that we evolve around the kids actually can come right through the patient's lifetime, where we can offer them, the optical does cataract assessment. You can see the cataracts changing if they had premature cataracts. We can do OCT assessment of discs and the macula. And also we want to probably be looking at things like this, where we're doing, rather than dilated fundoscopy, we're doing comparison year-on-year imagery of the far periphery of the eye. So a myopia management plan should not just be for the kids, it should be for adults too. So axial length is important for identifying children at risk in that pre-myopic stage. And also it's much more accurate from the point of view of predicting how patients are responding and showing them the response that they get. So there is advantages from that perspective. And also it can help you identify myopes that have got really long eyes, so you're going to be more kind of forceful in your advice and what you're going to prescribe to them. And then also, again, it helps us with these adult myopes. So there we go. That's us come to the end of the time. So hopefully you have found some information in this that's helped you move up the ladder a little bit. I'll cut back to Stuart, hopefully, and he may have any questions that we've got. Hopefully you've got some easy questions, and these are some of the resources that I use and I'd like to recommend to you. Particularly three speakers, Mark Bullimore, Jeff Willian, and Noel Brennan are great speakers if you get a chance to see them at conferences.
Perfect. Thank you, Scott. So we have got some questions. They are probably easy questions for you, but we'll find out. So what I'll do is I'm going to just put the QR code up on the screen, and then if people want to start sort of scanning, you can scan and get your certificates. And then I will just get the link as well. So I'll pop the link in the chat, and then you can access if you can't scan the QR codes. So in terms of questions, we've had a few that have already been answered during the chat. So let's have a look. So in terms of stats, so what are the stats of slowing progression of myopia in ortho K versus daily myopia control specs? So you might want to just touch on this one as well, in terms of just how much reduction do the two sort of methods, or the three methods, comparatively do?
The website that I referenced, the myopiachat.org, if you go to that and you go to the resources tab at the top, you'll see that there's a link there of the references that they've got. And I've got three, effectively in the references section, I put the percentages down. And these are the percentage from, so I think it's the MySight study, which is the one of the best studies that's been done from a clinical perspective for the soft lenses. I think it was the Hoya study, which had gone to 3 years at the point that we put the information up on the website. And then it was a meta-analysis. Because Ortho K has been around for much longer in research, there's meta-analysis information for it. So it was a meta-analysis study. And effectively, but they're all limited to this kind of 2 or 3 year period. And to get a comparison, you're never going to get a true comparison on a clinical study that's over a longer period of time. So they're all roughly the same, around about, say, 60 odd %, which is why I'm not overly fussed. And okay, so let's see, the percentages are there and they're all roughly the same. One of the things that highlights kind of how selective the clinical studies would be is if you look at the MyoSmart study, the Hoya study, the average myopia induction into the group was -3, which is way different, I think, than we would have in practice. We're going to have patients going into this at -1, but in the clinical study, it was -3 when they started. So it just shows you that a clinical study is a kind of bubble of patients, not necessarily relevant to the individual that we're going to see, which is why I'm not overly fussed about which. I'm going to go with the one that's the most compliant when I come to prescribing.
Mm-hmm. Yeah.
And just to follow on for that, I'm sorry I rabbit on about this, but I love it so much. That if you compare 45%, so that if you look at the CooperVision study where they got 1 mil of change over the 6 years, which means that they got 0.5 mil of reduction. So if you compare that from if they had a 45% efficacy versus a 55% efficacy, actually the amount of axial length difference that it makes is only like maybe 0.1 of a millimeter. So a really small amount of difference. So we're not actually that bothered about is it 45 or 50, because over the time it doesn't really matter. The big improvement we can get is this early treatment, and then them being in a device that seems to be proven to be effective.
Definitely, yeah. I think that's fantastic. But I like the line about 90% of patients benefit, because I think that's to me that's a much easier way to explain to a parent or a patient, rather than the 50-60 efficacy and potential reduction, etc. How many people benefit from it is definitely an easier way to come across it. Next question. When recommending time outdoors, some parents ask whether child should be wearing sunglasses. So is it the UV exposure that helps reduce the risk of myopia, or other light factors? So should kids still be wearing sunglasses?
I think I've only seen, yes, they can still wear sunglasses. I think there has been clinical studies on this. I have a vague recollection that it might have been, I can't remember, but no, the wearing sunglasses doesn't reduce the effect of outdoor time. Again, it was probably done in Australia, or if you're in Scotland and you wear sunglasses, then you might be getting so little light through that it might actually affect your patients. But no, sunglasses are still appropriate to recommend for kids. They still get the benefit.
Perfect. How often should contact lens checks be for ortho K lenses? Every 6 months or every 12 months?
So I change lenses every year, and I normally do annual checkups as well. So a patient gets issued a lens, I then do the follow-up to review them with that lens to make sure it's okay, and then I know that the lens that they're using for the next year is appropriate. There's a caveat to that, which is that for under 16s, the Pauline Cho ages and ages ago wrote a sort of good clinical practice guidelines that recommended 6 monthly checkups for under 16s for kids. Part of the reason, the methodology for that was most of the world then is in America or in Hong Kong, where patients pay for every appointment that they go to. So rather than waiting on the patient to come in for the checkup, it was very much a prescribed, you will come in and get a 6 monthly checkup, so that they came in and do it. Now, in Britain, because we tend to work on a care plan where we have an open door policy, patient gets a red eye, they can come in at any time. It's probably not as critical, but for kids wearing lenses, I do set them up for 6 monthly checkups.
Mm-hmm. Cool. What's the highest SIL power that can be corrected with the night lens?
You need to watch my video. I'm going to say none of it. Now, and this is the pathology. So this is the marketing information that goes around this is just so misleading. So there's a difference between, so that patient there that I showed, the -13 that got brought down to, or the -11i got brought down to effectively a -0.5. Okay, that's a super unusual case. It's the thickness of the epithelial cells that we can change to create the refractive power change. The treatment zone gets smaller the bigger we go. So let's look at a cornea. like my thumb. So the cornea has a flat curve and it has a steep curve, and it's going -3 that way, and it's going, there's a 2 diopter cell. So it's going, that means that it's going -3 that way. So there's 5 diopters going up and down the way. Now, the rule of thumb is that you're going to get a spherical correction. So the same optical result you would get if you wore a soft spherical contact lens, because that's going to mold to the corneal shape. The treatment zone that we're going to get a 20 micron thick treatment zone change in the horizontal. We don't induce a 50 or 60 micron thick change in the vertical just because there's astigmatism there. The tear lens of a night lens is spherical, so the tear lens that's underneath that lens is trying to reduce all of the astigmatism. But so effectively, the lens will try to correct all of the astigmatism, no matter how big it is. We'll try and reduce all of it. What actually happens is you end up with a best vision sphere of correction. Now, you saw the topography there, the patient's prescription had come down. That often happens. And I would say probably on average, we're going to see about half, a reduction in maybe half of the astigmatism for centered treatment zones. Now, again, the treatment zone will be determined by the peripheral corneal shape. So the treatment zone needs to be on the visual axis to get a good reduction in the astigmatism. So it's really hard to predict. So basically, for an outcome, anticipate you're going to get a spherical correction. It's the pathology of the cornea that limits us. It's not the lens design. The lens designs are all trying to correct it. The tear lens under an optic lens would be correcting all of the astigmatism.
Excellent. Cool. Up to what age would you recommend myopia control?
Another win for night lenses, because of course patients go on to them, they love them, they just stay on them their whole life. Mark Bullimore is doing a lot of work just now on modeling, and the progression of myopia that we see in the kind of the 20s also seems to be axial. I think it was assumed that might become a little bit lenticular, but its axial length growth is showing to be continuing through the 20s. So in theory, you want to effectively leave patients on some degree of it. But of course, the progression, the amount of myopia that they're going to have progressing in those 20s is going to be so small. If you were to half it, it probably gets to that cost value benefit where it's not going to be much worthwhile. But certainly we want to be doing it up until, for Caucasians, probably up until 2021, I would say most of the time I would expect patients to stop.
I think that's going to be something that we're going to find out more about as we've got patients that have been through years of myopia management, and whether we're getting rebound and stuff like that, I suppose, isn't it? So that will be an ongoing investigation. Have you met anyone offering corneal cross-linking with ortho-K for ametropia or early ectasia treatment? Is it effective and stable?
You don't need, there's no advantage in cross-linking from the point of view of benefiting of orthokeratology. The keratoconus is you wouldn't do orthokeratology in somebody you knew had keratoconus. If somebody had very mild keratoconus and then they'd had cross-linking, their cornea, if it was stable, I would then say, well, you're not changing. So keratoconus is a disease of the stroma, and we don't change the stroma when we're doing orthokeratology. We're only changing the epithelial cells. So effectively, if the strobel is stabilized and that patient was caught super, super early, like they'd have to be like really early in the keratoconic phase. They probably have one eye that was worse that wouldn't be suitable, but then in theory you could fit them with ortho-K. But no, it's not the two separate worlds. Effectively, it's not that we do cross-linking to enable us to get a different result with orthokeratology.
Cool. I'll ask both these questions in one go. I think the answer to the second question is just going to be yes, but we'll find out. So first question, what is the percent of rebound post-ortho-K? For example, in the patient who's been wearing ortho-K for 15 years, and would you recommend ortho-K for adults, especially high myopes and changing RX?
So Rebound, effectively the patient will go, so that the kid that I put up, so I put up two topography plots. One of them that had the kid that had stabilized, and they were 11, they were minus 2.3, they finished age 22 and they were minus 2.4. The other one that I put up was the kid who started when they were 8 at minus 250 and they got to minus 4. Now, he actually got a corneal abrasion last year and stopped wearing one contact lens. And we said, well, actually, just come out, let's see where you're at. And he was a minus 450. So the effectively, he's not getting, is that rebound? That's progression of his myopia, because he went in when he was 8 years old and he was a minus 250. The axial length will have increased. We increased the power of the treatment zone by increasing the power of the night lens, but the treatment zone on the cornea was measured minus 4, and when he came out, he went to minus 450. So you won't get a rebound, and there's no rebound effectively being shown with the myopic control elements if patients stop. So this spherical aberration or the aberrations that go into the eye, whether it's with my site, there was no rebound. Whether it was with, I think, Hoya, I've also shown there was no rebound. And it's the same with the ortho case studies. So we don't need to worry about a rebound effect in the same way that we saw the massive rebound effect with atropine. We don't see that with the optical corrections because, again, it's a different mechanism. This is working on the choroid with increased blood flow, bolstering and stabilizing the sclera.
Okay, we've got six.
Yes, they're suitable for adults. I always so again, you're going to provide the patient with a distance center cornea with an ad that's equivalent to, so high myopes. I'm always wary about the quality of the vision, but for adults, the main advantage is they don't get any contact lens discomfort. So that's why it's a really good mode of wear for adult wearers. High prescriptions, I'm always a bit wary of the quality of the vision and the outcome. I'm wasting my chair time, wasting the patient's time, them coming in not being corrected if they're super high. I'm going to expect a good result up to minus 5. Over a minus 5, you're into that realm where it just might be more problematic.
Okay, so we've got 6 more questions. So shall we fly through those?
Yeah, short answers. Yeah, I know you've got football to get to.
No, I'm fine. The most important game's tomorrow night. It's Villa, but I'm away anyway, so I'm going to miss it. So is there a table available where we can see average axial lengths depending on age and RX?
Average axial lengths.
I would suggest if anyone wants to find out general information about myopia management, then myopiaprofile.com is a really good place to start. And for your patients, mykidsvision.org is a fantastic resource as well. But Scott, if you know any more.
Yeah, so the one that's probably relevant to that answer is I've forgotten what it's called. It's going to skip my head. So it was the Catherine Saunders. It was the where you can. So look up Catherine Saunders. I've put the table up in my previous talks where you can look up the keratometry to estimate the axial length. That's probably the best resource, and that's also based for Caucasian population, I think. So,
have you noticed any axial length reduced progression for progressive adult myopes using ortho-K?
No, so I haven't. We've only had axial length in practice recently. So all of the night lens patients that I've got, I haven't got axial length data with them. It's always just been refractive, but. No, but you hear these anecdotal ones of patients that or optoms that say I've got a reduction with a patient.
Okay, perfect. If you have no way of measuring axial length, how can you tell the myopia is progressing if the patient is already wearing ortho-K and it shows plus 7.5 over refraction at the aftercare appointment?
So your treatment zone shows you the power. So what you would expect there. If you're seeing a plus 0.75 and the patient's treatment zone last year was giving you a measurement on the subtractive of a minus 3, and the treatment zone measured this year was also giving you a minus 3, and you've got a plus 0.75, then it looks like you've got that there's been a reduction in that prescription. If you've got the treatment zone is measuring more than it could be, you've not got a Scott lens lens, it's maybe a little bit off and it's given a bit more correction than you thought, or there's something going on. There's an external factor there that's caused you to get more treatment zone, but your topography treatment zone tells you the power difference. So if your cornea was exactly the same as it was last year and you've got a different refractive result, then you're thinking it is refractive. And that would be the same if it was myopia increasing and you had a minus prescription.
Okay, lovely. Quick recap how aberrations change choroidal BLD flow and therefore the shape of the eye again, please.
So aberrations go in, and let's say positive spherical aberrations. So we've got two spherical aberrations. We've got positive and we've got negative. Negative is what we induce with a single vision lens. So if you put a single vision lens onto an eye, within minutes, the choroid thins. We see less blood flow in the choroid. If you put in a lens that's inducing positive spherical aberration, so a myopia control lens, the choroid within minutes thickens and the blood flow goes into the choroid and thickens it. And then longer term, that blood flow is thought to then go into, we haven't proved that bit yet, but we think that the blood flow that's in the choroid is then bolstering the sclera. So that's the principle behind it.
Perfect. This is a very quick question. It says, do you do an ortho K myopia management lens like number 7? But the ortho K itself is a myopia management lens, isn't it? So
yeah, our lens is for the use with myopia, or for use with myopia control. Yeah, but so the number 7 one, they have a standard design and they have a smaller optic design. With our one, you can customize the optics to the size that you want. So our standard lens has got a 650mm optic. So what I do is I would start all my kids. So how effective is ortho K? Well, as Mark Bullimore says, it's as effective as my sight. So just the standard designs are as effective as my sight. So I start with a standard design, which is going to give me the best possible visual acuity outcome for the patient. If that young patient, once they've got used to handling lenses, they come in, they're 3 weeks in, 4 weeks in, wherever it happens to be, they've got 6.5 acuity. I would then think, right, I'm going to order a replacement lens with an optic that's 1mm smaller. So the number 7 design is a 6mm and a 5mm. So I would go with a 6. I could go down to a 5, but I would normally just go down to a 550. Order those lenses. The patient can then say, yeah, the vision is still adequate, so you're providing the smaller optic. But the evidence around the evidence around the benefit between a standard design and a smaller optic design, like I say, I'm not entirely convinced by the evidence that I've seen around it.
Excellent. And finally, my problem is I work in a university town with a lot of Chinese patients who will arrive in my room having lost their lens and never have any details of what they're wearing. So how can you help in that situation?
So if they've lost their lens, then you're able to go back to just a baseline cornea, so they will have washed out. Now for washout, you want to have the patient out of lenses for at least 4 weeks, possibly even 6, to get a good baseline map. So if they've lost their lens, you're just going to say, right, you can have some soft lenses or specs or whatever until you get back to that baseline measurement. And then you're effectively just going to start from scratch. And again, our lens has got a 92% success rate, so you're just going to start from scratch. So that's absolutely fine. It's probably better than trying to replicate from data. We quite often get sent through scans of a lens and we want to replicate it. You're probably better off just starting from scratch and doing a washout if you can. If they've got the keratometry, sometimes they come with a file with information. Then you can use the spec prescription and the keratometry and effectively do as a Ks and Rx design. And again, that lens is in our 92% set. There's loads of practices that use Ks and Rx to design the lenses. But just get in touch with us and we can look at the information you've got and we can usually get you sorted out or tell you how to sort the patient out best way.
Perfect. Excellent. Thank you, Scott. Scott, anything you want to add?
No, just thank you very much for coming and signing on and watching the presentation. And if you've got any feedback about it, I'd love to hear it, positive or negative. It'd be great to get your feedback. And if you enjoyed it, tell other folk about it for the next one. We've got another one coming up in a few months, I think.
Definitely, yeah. We've got a few scheduled with Scott Lens, and obviously it's fantastic content. So I really appreciate them taking the time to come and talk to you all. And thank you for having such a fantastic turnout. So we'll let you